giving handoffs or talking to them about better handoffs or something that occurred overnight that you thought was maybe due to a poor handoff, you can always refer back to some of the skills that I'm going to teach you in this lecture. So if you were at the last, our talk in the beginning of August, we gave a snapshot of what a handoff looks like, and this is really what maybe a not so good handoff looks like. So we'll watch this video and then tell you about how you can make it a little better.
Sorry I'm running late. It's such a busy clinic. I have like 4 school physicals. I hate all that paperwork. It's always supposed to be wrong. I know. Tell me about it. I had a clinic like that last week. Anyway, I'm not sure tonight's going to get any better. We have a lot of really sick patients on the floor. So here's your handoff sheet. Should we start with room 1? Sure. That's James. He's a 13-year-old with sickle cell disease. He's been here for about 2 days with leg pain. He thinks of vaso-occlusive crisis. He was admitted here last year or 3 months ago maybe with the same thing. His pain was very difficult to treat at that time. Yeah, I remember he was on a bunch of different narcotic medications. I don't really remember the exact regimen. Yeah, so we have him on a morphine PCA right now with no basal rate. I think his pain is well controlled, so you shouldn't have any issues with that overnight. In fact, we were actually thinking of transitioning him to PO pain meds, but he's on clears only now because of his respiratory status. For respiratory status? I thought he was here for a vaso-occlusive crisis. Sorry, he actually has been tachypnic to the 30s and hypoxemic. He was on 2 liters nasal cannula O2 earlier in the day. We were able to wean it back to 1 liter, and he was actually off O2 for a little while when he went downstairs to get a chest x-ray because the nurse forgot to bring an extra O2 canister down the window. Yeah, but she did that. No, I'm not kidding, but he actually did okay. He is back on 2 liters now to maintain his stats, and I shouldn't forget, his chest x-ray did show a right lower lobe infiltrate, so you may need to repeat if his respiratory status worsens. So do you think he has acute chest? Yeah, I mean, he meets the criteria, although nowadays it really depends on which hematologist you ask. So let's see what else. Oh yeah, he spiked a fever to 39 today. We were called about his fever during the conference, of course, but we got the blood culture when we got back. And he was surprisingly really. The nurse took 3 tries. I got on my 2nd try though. Thank you. So pop the follows culture, see if they grow anything. He's on ampicillin sulbactam right now. Dr. Smith says this covers the common respiratory pathogens. If the culture comes back, you may need to switch him off. Anything else? Let's see. Well, the regular stuff. Watch his vital signs, his getting pain scores. Watch the eyes and O's. He may have some electrolytes pending. So I think that's it. The hematologist number's right there. You can call him. Thanks.
Okay. Does anybody have any thoughts about that handoff, how it was? That's pretty typical of handoffs, if there were good things, bad things. Okay, good. Do you think it was, like if you were listening to it, would you have a hard time following it? Maybe. I mean, did she provide good information about like if something happened, what to do next? I think sometimes she did, sometimes she didn't. There was also some side conversations definitely about what had happened during the day. So these are all, this is really probably more normal than not normal in terms of how handoffs go. And we really encourage we teach the residents, and now we're teaching you about effective ways that you can perform a handoff better. So first, there needs to be a leader and an unambiguous transfer of responsibility. Most of the time, that leader is the giver of the handoff. And if you're having a team handoff, you need a clear leader. So I know in the NICU or in the PICU, they do team handoffs. So there really does need to be a leader at that time. There also needs to be a protected time and space. This is something that the residents struggle with this often because obviously the 5 to 7 o'clock time is really busy. There's a lot of admits coming in and so forth. So one thing that you guys can do as fellows is be protective of that time. If there's a patient that you know of that's coming during that time, make sure that they're not handing off. If they are handing off, you could, if it's not an emergency, if it can wait, just to have them call you back. Or send non-urgent pages, something like that. And then, when you're handing off to each other, find a protected time and space for yourselves. I mean, so handing off in the while you're on your way to work in the car is probably not the best way to do handoffs. Though admittedly, I've definitely done that before myself as a hospitalist when I'm receiving morning handoff from the person who is on overnight. Also, everything should be up to date, accurate, and relevant. And with constantly changing information, this can be difficult, but this is what is definitely you should strive for. And then one of the things that we do in the resident teaching is we teach them about learning styles. They do a learning styles evaluation prior to the conference that we give, because everyone has very different ways that they learn. So some people are very visual learners, some people just read, some people are very oral, some people are very detailed oriented, and some people are very global picture. And so when you have somebody, I think one of the bigger problems happens is if you have somebody who's much more global picture orientated handing off to somebody who's very detailed oriented, the detailed orientated person is like, you've got to give me more information, and they feel very dissatisfied at the end of the handoff, and vice versa. If you have somebody very detailed orientated giving somebody who's very global picture, they quickly get bored and stop paying attention. So you don't need to change your style completely, but just being aware of the people that you frequently hand off to and sort of what they like, and catering to a degree. I mean, obviously if you're very global, you can't be completely detailed, but you can be a little more detailed for that detailed orientated person than you would be normally. Also, keeping in mind level of training. So, oftentimes I think as fellows, you might hear of admits coming in. You need to tell the residents about those. So you need to be cognizant of their level of learning. If you're handing off information to a senior, you can be much more high level. Versus if you're handing off information to an intern, definitely you need to think about things that you might presume that they know that they really might not know. Also, knowledge of patients. So obviously, brand new service, first day, you're going to need to give a lot more information than if that patient, if you know that patient very well and you're just, getting morning sign out from the team, from an overnight person, and you've been following that patient on a daily basis. And then clinical experience. And then really, I think this links back to the first lecture, if you didn't attend, but the concept of a shared mental model. So it's just like you're thinking what I'm thinking. And that's through active participation of the receiver. So a few years ago, there was a good article that was published in Pediatrics, I think in the e-publish, but they did a study where they looked at what receivers thought they heard and what givers thought they gave. And really, there's vastly different perceptions there. And so having the receiver actively participate in the handoff can improve that communication. And the more familiar you are with the person, the more likely you are to presume that they know more than they actually do. So it can be a little dangerous. So those are global handoff things. In terms of the verbal handoff, it should be a structured format, beginning with a high-level overview. So this is something that the residents, just based on feedback that we've been getting from faculty right now, don't do that well. So if you ever listen to the handoff, or if you're ever preparing them at nighttime or working with them, making sure that they know what the high-level picture is of the patients that they're taking care of. So who's sick, who's not sick, who's coming in, who's being discharged, things like that, and just the high-level overview of the team. And then an appropriate pace, so not too fast, not too slow. They generally do pretty good with that. And then, again, that closed-loop communication so that you form the shared mental model. The printed handoff document is also important. How many of you guys use the MD sign-out reports and find them useful? So a few of you do. So I think we've been trying to make them more accurate, but they should not be running discharge summaries. They do require daily updates. We really ask that the seniors update them. So if you're, ever on the inpatient service and you notice that the handoff is your sign-out form is really up to date, you should talk to the senior that you're working with about that, because really they're supposed to edit and ensure the quality of the final product. And it generally provides much more comprehensive information than what is given in the verbal, and allows the receiver to sort of follow along. When they're up to date, I find them very helpful, but oftentimes they're not. And a good way to know is in the little gray bar at the top, it will say the last time it was updated and by whom. So, if you see that it hasn't been looked at in a number of days, there's a problem. And so then the iPass mnemonic. So this is the way that we teach them to give handoffs, and you might be using this in some settings. So like the OR to the ICUs, they're trying to do this from the PACU to the floor, the OR to the PICU to 1 North. A lot of different settings where you might be instructed to use some version of iPass. It's a little bit different depending on the setting that you're in, but this is the way it's taught from the standpoint of a shift to shift handoff. And this could be considered, and you can consider this in a lot of different settings, like when you're giving a handoff to like a outpatient provider, if you're giving a handoff to a provider that's going to continue care, like at an outside hospital or something like that. And if you want to, I'm going to hand out these cards so you can follow along. If you have a card already, it's fine. But do you mind handing them out? So, and all the residents have one. They probably, some of them have lost them. It's fine, but they're available if you need one. The IPASS mnemonic, so I stands for illness severity, P stands for patient summary, A stands for action list. The first S is situational awareness and contingency planning, and the next S is synthesis by receiver. And we'll talk a little bit about what those mean, and then we'll give you some time to sort of practice signing out to each other. So first, illness severity. So it's really a continuum, and we really want to assign some common language to it. So they should be identifying the patients as either stable, watcher, or unstable. Clearly, an unstable patient shouldn't be on the floor. So you might have unstable patients in the PICU or in the ICU, but if they're talking about an unstable patient on the floor, they shouldn't be there. So most of the patients on the floor will be stable or watcher. But like I said, in the ICU setting, you might have an unstable patient. And they're really, a watcher is really any clinician's gut feeling that the patient is at risk for deterioration or close to the edge. So sometimes you might hear the residents use it for like a patient who needs a lot of labs that night. That's really not the definition of a watcher. A watcher is really somebody who you're worried about their airway. You're worried about their cardiovascular status, something like that. So this is a terminology that should be used. You should try and use it yourselves and make sure that the residents are using it as well. And you can even use it like when you're talking to them or talking to your colleagues about any sort of patient. The next is the patient summary. So we're not going to spend a lot of time on this, but we really do spend a lot of time on this with the residents. They're interns, they really need to work on their summary statements. We encourage them to use include the events leading up to admission until the diagnosis is well known, just so that it keeps your mind open, so that you don't come to premature closure on the diagnosis of that patient. And then the hospital course, the ongoing assessment, and the plan. General statements about high quality patient summaries, so they really facilitate the transfer of information and responsibility. This is really where like the meat of the handoff is, and where things can easily be omitted or misinterpreted. So that's why we really do have them work hard on this area, and you should practice working on it yourself. Then we also want them to transmit the information concisely. So, and we'll get to how you might do that in the next slide. And then unique features of that patient's presentation, so things that are not common. So, a patient with bronchiolitis is pretty standard, but a lot of our patients here, obviously, we know are not. So, those details of that patient that they really need to be aware of. And ideally, it's creating a shared mental model so that, basically, you're on the same page about that patient. So what, as the giver, I felt was going on during the day, you feel that's going on during the night, or when it's like a Sunday to a Monday shift, or let's say service change, what was going on Sunday doesn't all of a sudden change because the person who took over has a vastly different idea of what is going on with that patient based on the handoff. And we teach them how to use semantic qualifiers. These are, I think, hopefully you've used these and maybe you're not aware that you use them, or maybe you can use them a little bit more often. But they're really, they're dichotomous qualifiers along an axis. So they're terms to more simply explain something that we often use many words to do. And they enable clear communication of very representative clinical features. So, for example, the onset, so acute should bring something vastly different to mind than something is chronic in terms of not diagnostically, but also sort of plan-wise. And encouraging them to use that terminology is helpful, and it's helpful for setting the stage in your mind as to what is going on with that patient and creating that shared mental model. Same with severity, mild, moderate, severe, context, nocturnal at rest, patient characteristics. These are, again, just different semantic qualifiers. Then the action list. So these are really what needs to be done. And so what you sometimes will see on the handoffs, or the printed handoff, is like things that need to be done. like 3 days later, and that really shouldn't be there. It's really, and they shouldn't be talking about that. I think generally they don't talk about it, but oftentimes you'll see things like that are reminders for themselves to do the next day, and that's not really what the action list is there for. It's really what needs to be done that night, what that person needs to look out for. So examples, checking the respiratory exam now and then every 2 hours overnight. Timelines are good. You know, saying that a vanc level is going to come back is not very helpful if you don't know when it's going to come back. So it's really nice to know, like, or to be clear about like when it's coming back, so that, you know, if the expected hour goes by and you still haven't received that, you still haven't received that lab, or you haven't had a phone call or whatnot, you know to look into it rather than just, you know, continue sleeping through the night or whatever it may be. And then sometimes what to do. I mean, you can't. Well, the action list. You know, if you expect certain things to happen, like what to do about them if they do. So like, you know, check the electrolytes because if the sodium is low, this is what we want to do. So just being very clear about that. And then I think this is a big thing, the situational awareness and contingency planning. And this is something that you can think about on a daily basis. You know, when you're rounding or you're, you know, preparing for a patient who's going to be admitted, and talking to the residents about that patient or each other. It's really like knowing what's going on around you. So the status of the patient, the team members, the environment, and the progress towards the team goals. But really, when we're talking about the handoff, we're talking about the patient level. So what's going on with the patient, with your patient, and what the status is, and what you expect to happen that night. So it's always helpful, you know, if you have a clear plan in your mind for, like, let's say if the patient has a fever, you should make sure that the people are aware of what they should do if there's a fever. Because I think oftentimes people presume that they should do something, but if you have something that you really want done, that should be part of the contingency plans. Also, contingency plans are good, like if you know that something has happened before in the past. So like this patient has had trouble with blood pressure and this is what we've done and this is what's helped. That is also like part of situational awareness and contingency planning, and can be very helpful for the night team, or, you know, for the person temporarily taking care of that patient, just so that the plan doesn't get derailed because they do something vastly different than what you like intended to be done if that situation happened. Also environmental factors, so this is where a lot of times like the psychosocial issues that come up are helpful to know about, and then the progress towards goals of hospitalization. So where are they at in their discharge process? So if you know if you're planning to send that patient home the next morning, that should be like part of your situational awareness, so that they're aware that this patient's like the goal is to go home. If this happens, we should know about it, or if this happens, you know, don't worry about it because again, they're going home. So. And the same thing, it's contingency planning. So, like, you know, problem solving before things go wrong. So, I mean, I think, again, when you're rounding on the inpatient units and you're trying to help the residents prepare for the night, or you have particular things that you would want to go a certain way, that it's good to have them think about it. It's not only for good patient care, but it's also a good, like, exercise and learning exercise for the residents themselves, and when you're communicating to each other as well. Like, it's good to use these plans so that you know, one fellow's plan isn't derailed by the next fellow's plan. So, okay, so I think I already talked about that. Oh, the other thing is to identify resources for assistance. So who they should call if things go wrong, like where's the chain of command? Because I think oftentimes, or what I've seen happen sometimes, is the residents don't even know to like call the senior if this happens, or they don't know to call the fellow if this happens. So being clear, especially being clear with them, like when do you want to be called? Because otherwise, sometimes I think they do things because they're afraid to call at night, or maybe they think they can handle it, or they know, and it's like early in July, and clearly they might not have a great idea. So you know, if you want to be called for everything, great, but just let them make sure that they know that. But probably you don't, so just being clear about that in your planning with the day team or even the night team. So, and then finally, this is a key. The synthesis by receiver. This is the one that I think people struggle with the most, including myself. I mean, I give frequent handoffs as a hospitalist when I do nights and days. This is where the receiver clarifies the elements of the handoff, sort of gives a summary statement of what was going on with the patient, and like any important contingency plans or action lists for that night. It's not a restating of the entire verbal handoff. So we, as hospitals, we take care of the bone marrow transplant kids at night, and I use this frequently just so that I reiterate like what in my mind I heard is the key issues that need to be handled and what I'm supposed to do if something goes wrong. And I clarify, who's sick and who's not sick with them. And I do think it's helpful, but it's really hard to get in the habit of it, I'll admit it. So, but if you can encourage your residents to do it and if you can do it yourself, and it's not a restating of the whole entire verbal handoff. I mean, it's, it should not be taking 5 minutes to do synthesis. It takes probably like 15 to 20 seconds, maybe like 30 seconds on a more complicated patient. So really that's IPASS. So with those sort of techniques in mind, you're going to watch that same handoff using some of the IPASS mnemonic and some of the things that we learned about and how it might go better. So.
Oh, so sorry for my clinic. Was really busy. I'm ready for the handoff, and I checked with the nurse station, and there don't seem to be any urgent issues. Great. For an overview, there's two boxes on our team. Here's the handoff documents. I just finished editing. Okay. So first is James. He's one of our watchers. We check on every 2 hours tonight. James is a 13-year-old with sickle cell disease who's admitted for vaso-occlusive crisis. His previous history is that he has had multiple admissions for vaso-occlusive crisis in the past, as well as acute chest, the last being 3 months ago. Acute issues leading to this admission was that he was admitted 2 days ago with leg pain and has been treated with morphine. Today he developed a fever to 39 degrees Celsius. He was hypoxemic and now he has pretty lower low impulse rate, so he's developed acute chest syndrome. For my problem list for his acute chest syndrome, he's been tipped into the 30s, hypoxemic, and is requiring 2 liters of nasal cannula oxygen to maintain his saturation. He has crackled at the right pace. We sent a blood culture this afternoon, and he's now on anticultural doctor for his vaso-occlusive crisis. He's been comfortable on morphine PTA with 1 milligram of and no nasal rate. His pain scores have all been under 3. For his anemia, his baseline hemoglobin is 8, but we did transfuse him to a hemoglobin of 10 yesterday. So our working diagnosis is that this is a 13-year-old male with sickle cell disease, initially with vaso-occlusive crisis, but now with acute chest syndrome. He has become febrile and hypoxemic, so needs careful monitoring of his respiratory status and his pain control. So if you could please check on his respiratory status now to get a baseline, and then frequently throughout the evening, he needs his pain scores monitored as well. If he becomes more tachypnic or more hypoxemic, I would repeat his chest x-ray to see if he's developing worse infiltrator effusion. You should call a rapid response if he worsens, as he may need to be transferred for CPAP. And then remember to update Dr. Smith, the attending hematologist as well. And that's what I have on this. All right. So let me just make sure I have everything correctly. James has sickle cell disease, and he was admitted for a vaso-occlusive crisis, but now he's developed acute chest syndrome. We need to monitor his respiratory status very closely overnight. If he has worsening tachypnea or increasing oxygen requirement, I'll go ahead and get a chest film, call the rapid response team, and also let Dr. Smith know, just to kind of keep him updated. And the only other question I had was related to his pain control. Would you consider adding on vasorate of morphine in case his PRN isn't working? Yeah, if he needs to go ahead and add a basal 1 milligram an hour. Great, thank you.
Did you guys notice some of the techniques, saw the IPASS being used? Hopefully you saw how much better that was than the first handoff. Again, they were focused. There was a clear action list. There was clear contingency planning. She, gave the synthesis, repeated what she thought was essential, asked questions, and hopefully they walked away from the night with a shared mental model. Also, she gave an overall picture of what the patients were, or the patients on the team. There were 2 watchers, sort of set the stage for what the overall handoff would be. So if you want more information, or if you ever watch a handoff and feel like the residents need more training, or if you want to get more information yourself, there's this IPASS handoff study website, and also on MedEd portal. A lot of our training modules have been published there, and you can access the materials there here at the IPASS handoff study as well. And so now, really, I'd like to spend the last 20 minutes or so with giving you just a chance to practice using the IPASS mnemonic and some of the techniques. So basically, if you can divide into groups of 3, one person will give the sign out, one person will receive it, and then the other person will observe it. We'll give you all packets. So the person observing will use like the observation sheet to sort of record their findings, and then you guys can give feedback. If you brought your own handoff, that's what you should use. Like if you're currently on an inpatient team or if you're on an outpatient service and you need to hand off a few teams. If you didn't, we have like fake patients that you can practice signing out. And just, the residents do spend time doing this, and we set up scenarios where, one person is really stressed out because they're coming late from clinic, and the other person is really derailed because the person who's giving the handoff is derailed because they've had a rough day. And we sort of practice scenarios like that and what you would do in that situation, because I think, that is the reality of what happens oftentimes when we give handoffs. And there's a time and a place for that, but when you get into the actual handoff, it should be dedicated to the patients and what you're giving and receiving. And that's it. And just, this is mandated, like ACGME requirements, everyone has to have handoff training, so we're checking another box. But I do think it's important, so I'm not, well, but I feel for the people here who are residents and for this. So who needs, let's see, you guys want to be a group of 3? Sure. Do you have a handoff? Do you want to start practice? Perfect. You want to have it?
Sorry, we already have a group.
That's all I have, so.
And then they took it away, so I'm not sure if you move the mic down when there's a table that will have.
I did.
They're doing it.
I know, I guess I'm supposed to, like, every time.
So that's not even not. No, I don't. Just say over same interval. But just